This is the respiratory disorders lecture. It is going to be a little bit longer lecture as I'm going to voice over this PowerPoint presentation all together. So here are your objectives. We're going to focus on normal ventilatory and respiratory function. And then we're going to turn and focus a little bit on some of the determinants that are common in respiratory function in older adults. So some normal age-related changes. And then we'll go ahead and get into some of the pathophysiology of COPD and tuberculosis. So let's review just a couple of terms which are really important because when people get COPD, it affects these processes. So we're going to talk about COPD later on in this lecture. The first topic is ventilation. And ventilation is simply getting air in and out of the lungs. Air comes in through the bronchioles. So people that have bronchitis, chronic bronchitis or COPD, their ventilation or getting that air in and out is the main issue. Respiration is when you have gas exchange issues. So for people with emphysema, the issue is more respiration than ventilation. As nurses, we think about and deal with these in different ways. Breathing is controlled by the brainstem, and it's based on CO2 levels in the blood. So a high CO2 level in our pulmonary, a high CO2 level is our primary drive to breathe. A low oxygen level then is our secondary drive to breathe. Okay, so primary is high CO2, secondary is low O2. And this becomes really important for people who have chronic CO2 retention, okay, because that primary CO2 drive to breathe gets knocked out because these patients get so used to having so much CO2 on board that the brain just phases that out. So they are left with a secondary trigger, which is having a low oxygen level. So this is a reminder of what ventilation looks like. Or what I really want you to focus on in these pictures is where the diaphragm is, okay? So remember, we just described ventilation is the inhaling and exhaling. So focus on where the diaphragm is in these pictures. The muscles that control breathing are the diaphragm and then the intercostal muscles. So when we breathe normally, the diaphragm drives respiration. Okay, is the muscle that drives respiration. The intercostal muscles and the sternoclavicular muscles kick in to help with breathing, and those are accessory muscles. So if a patient needs to use accessory muscles, those intercostal and sternomastoid muscles kick in to help. And using those muscles are an indicator that their breathing is labored or there's something going on in the ventilation department here. So in people with chronic bronchitis, we see the use of accessory muscles quite a bit. And this has to do with respiration. Okay, we defined respiration, remember, as gas exchange between the alveoli and the blood. So this picture is an alveolus, and you can see here in the picture that the alveolus is really lined by capillaries. And what I want you to focus on in this picture is normally the alveolus is like a globular spherical shape so that all sides are touched by capillaries. In a person who has COPD or emphysema, the side walls of the alveolus get broken down by a protein called trypsin. And they then lose that globular shape, which means they lose a lot of their surface area for gathering or for doing gas exchange. they're left with a little flat part at the bottom, and that is how the respiration gets affected. So we talked about ventilation, the in and out, respiration, and gas exchange, what drives it, and then some of the abnormalities. Most age-related changes that happen in our respiratory system happen with ventilation, especially the muscles and the structures that regulate how deep the older adult breathes and how fast they can exhale. Okay, so how deep the older adult can breathe in and then how fast they can exhale. Okay, so changes mainly in those muscle structures that regulate that. So the first big change is the rib cage stiffens, and this means that the older adult has less room in their lungs for air because of the stiffening, and the ribs just aren't as compliant as they were when they were younger. There are fewer and less effective cilia also, and cilia motion. So the cilia, as you remember, just some of your pathophys stuff, are hair-like extensions, and they really line and form our bronchial cells, and they help you move mucus up the airway to get it out. So when someone coughs, that cilia can kind of help move that mucus up so they can cough, the person can cough things out better. For an older adult, they lose that cilia, and the cilia are not as powerful. So older adults often have mucus plugs and trouble coughing, especially coughing things up. Also, elastic recoil, which is a really important with ventilation because that is what lets our lungs kind of snap back to a deflated state. Okay, so the elastic recoil is obscured, or we have loss of elastic recoil. So after an older adult takes a breath, it's the elastin in the lungs that helps it shrink back down and let the air out. So when the older adults, okay, or when we lose elastin, we lose that recoil. And then the older adult also loses the ability to passively deflate their lungs. Okay, it means that you have to force the air out of the lung. Okay, so trouble breathing in, okay, because of the stiff rib cage and things on the slide, fewer cilia to help cough things up, loss of this elastic recoil. So the older adult often has to actively breathe the air out that they take in, and they have to breathe out with a lot more effort. And older adults, especially with breathing issues, then wear themselves out a lot quicker. And then the last thing is the respiratory muscles also weaken. And so it takes more effort also to inhale or breathe in and to compensate because the breaths are usually more shallow. And older adults also tend to breathe a little bit faster. Okay, so those are age-related changes that have to do with ventilation, getting the air in and getting the air out. So here's age-related changes with respiration. With respiration, there's really only one big change that has to do with gas exchange, and it's that there are fewer alveoli, which means overall, aging causes the older adult to have less of the surface area for that gas exchange altogether. Okay, so there's fewer alveoli just as a normal process of aging. So as long as the person can still function, or the older adult can still function and not get hypoxic with basic movement, it's fine. But if the older adult has shortness of breath and hypoxia, they become restless with minimal activity, that's a problem, and they need to get it checked out. A change that doesn't really fit into either category is also that there's less IgA, and this has to do with our immune function. So normally mucous membranes are loaded with immunoglobulin A or IgA. So this is like in our lungs, it's in our nose, it's in our urinary tract, it's everywhere we have mucosal tissue. As we age, our B cells can't produce immunoglobulins well, so in our nose and our nasal passageways, we don't get that good immune protection. So the older adult is more likely to develop colds, flu, other viral illness because of this less IgA in the mucosal surface. There's lots of things that determine the likelihood of respiratory disease in the older adult. By far, the biggest one is smoking. Whether or not the older adult smokes, or how much they've smoked, or their path per years makes a huge impact on how good their lungs are able to function. Other things like chronic exposure to allergens and poor air quality, being immunosuppressed, being obese, all of these things also can impact respiratory function as well. The most common respiratory symptom that older adults complain of is dyspnea and cough. And anytime anyone says that they have a cough, as a nurse, your next question should be, is it productive or non-productive? And that's a really important question. Another complaint the older adult might have is that they have a lot of sputum or a lot more sputum production. Chest pain is also a common symptom. In most respiratory conditions, the older adult will have one or more of these symptoms. However, the older adult may delay telling anyone about it because they feel it's normal and they minimize it. By the time an older adult actually sees anyone for some kind of respiratory symptoms or see for care, it's already pretty far along. Okay, the illness is already pretty far along. So when an older adult comes to the ED or the clinic, usually they come in quite ill compared to their younger individual counterparts at the same stage of an illness. The other thing about the older adult symptoms is they may present with things that are more vague or atypical. Okay, atypical signs of respiratory symptoms, such as confusion, loss of appetite, decreased functional ability, or all of a sudden they're just not themselves anymore. Okay, so those are atypical symptoms that older adults present with. Maybe they can't, another atypical thing is maybe they can't do what they used to do, or they get really tired with doing it. The older adult tends to decline pretty rapidly when they come in with a respiratory symptom, and they come in pretty sick right from the get-go. This is a really important point to remember for the rest of your nursing career. Basically, if someone comes in for chest pain or shortness of breath with activity, usually it's not as big of a deal than if they complain of chest pain or shortness of breath at rest. If the older adult is complaining of these things at rest, that means their body does not have enough oxygen to support their normal basic function. So a cardiac or respiratory emergency may ensue. We should explain this to the older adult, and they should contact EMS or go to the hospital immediately if they have dyspnea or chest pain at rest. That is a cardiac or respiratory emergency. Okay, so let's break down COPD now and see what it means. The first part, the chronic part, okay, is a gradual onset after chronic exposure to respiratory irritants. So just because the older adult has smoked 2 cigarettes in their lifetime doesn't mean they're going to get COPD. But if they've smoked a pack of cigarettes for 30 years, that chronic exposure to an irritant is what causes the chronic part of COPD. If they lived in an area with heavy pollution, or if the older adults worked in industries with heavy metal exposure, they could also be more prone to getting COPD than if they weren't exposed to that at all. Okay, and especially that chronic exposure. So like I said, not just one day, but it has to be a chronic exposure. The obstruction means or deals with the fact that exhaling is hard work. So rather than exhaling being a passive process in the lungs for that recoil back to a normal state, it takes effort and energy to breathe out. And remember, so that's obstructive. So it takes exhalation is an active process. Okay, so they have to actively exhale. And remember that coupled with the loss of elastic recoil, also with a normal physiological change. The pulmonary part refers to the lungs, but more specifically, it involves the bronchi. Chronic bronchitis or alveoli emphysema, and it can involve both, or COPD, which is not a normal part of aging. Okay, so pulmonary often involves the bronchi, which we call chronic bronchitis, or alveoli, which we mean as emphysema, or it can be both. Okay, pulmonary could be both. Okay, either, okay, is not a normal process of aging. And then the disease is COPD, again, is not a normal part of aging. So let's talk about chronic bronchitis and emphysema separately because the pathophysiology is a little bit different. However, chronic bronchitis, we're talking about bronchial tissue. And whether we talk about bronchitis or emphysema, okay, the first step is basically the same, okay, that chronic exposure of bronchial tissue to an irritant. So if an older adult is chronically exposed, okay, the cells that line that tissue, okay, of the bronchial um, really becomes irritated, okay? Those irritants are those things that you breathe in. And in response to that, the body puts out a ton, a ton, okay? So in response to this chronic irritant, okay, in the bronchial tissue, the body puts out a ton of neutrophils and cytokines. And then remember what cytokines are around. You're going to have some cells that change shape, okay, or change function. The bronchial tissue over many years then undergoes some pretty significant changes in their structure because of these cytokines, okay, and that chronic inflammatory process. One of the first structural changes is that the cilia, which are the first to flush those irritants out and move them out of the lungs, either by coughing or something, once they get trapped, those irritants become trapped in the mucus. The cilia can't really keep up with that demand, so they die off and they undergo apoptosis. Within the bronchial smooth muscles and the tissues of the bronchial walls, we're going to get a lot of swelling and edema. And this is in response to those cytokines. Then the goblet cells, okay, and these are interesting cells that are in the bronchial epithelium, and they're responsible for producing mucus. So when we have this chronic exposure and this irritation, the body tries to get rid of the irritant, and as it tries to trap them in the mucus and expel them, the cilia aren't really working. And as the exposure goes on, the mucus really can't keep up with the exposure, and the goblet cells can't keep up with the demand, so they start to increase in number and size. So that an airway that is very reactive, well, you end up with an airway that is very reactive and unable to keep up with the demand to get rid of the irritant. So you have a huge supply of mucus. And this is how chronic bronchitis happens. So with emphysema, as we said, the first step is the same. You have chronic exposure of the alveolar sacs to an irritant. But that irritant triggers an inflammatory response then in the alveoli, just like it did in the bronchial, except here in the alveoli, it has a slightly different impact. So if we think about the alveoli in the box here, okay, you can see where it says normal alveoli. And these are constantly going through breakdown and building back up. They sort of are constantly in flux. There are two proteins responsible for this: trypsin, which is the protein that breaks down, and antitrypsin, which stops the trypsin to keep the alveoli kind of built back up. So when you have this inflammation in the alveoli, you basically stop the antitrypsin from working. And because half of your equation isn't working, the other half has free reign. So your trypsin is constantly breaking down alveolar walls bit by bit until you end up with the alveoli labeled here as damaged in the picture. These damaged alveoli are flat. There's no walls in between them. And those walls, remember, are very important because it gives the alveoli that extra surface area for a gas exchange to take place. But now, because they don't have that globular or that spherical shape, all the person with emphysema is left with is the bottom of those spheres. So they become very flat. They lose a lot of their surface area for gas exchange. The risk factors for COPD are really pretty well understood. We actually know a lot about what causes and how to prevent this disease. The first risk factor is smoking. Okay, so smoking is a huge risk factor. The second risk factor is alpha 1 antitrypsin deficiency, and it's fairly common, especially in early onset emphysema, which happens in the mid 30s. Life expectancy of someone with alpha 1 antitrypsin deficiency is low. Maybe the person would survive into their 40s. Industrial exposure also to things like organic pesticides, industrial irritants like solvents, heavy metals from the mills, also mining work. And in mining work, there was a lot of silica in the mines. Okay, so the older adult could have silicosis, okay, or silicosis, or they could have sarcoidosis, okay, or amyloidosis, which look a lot like emphysema, but through biopsy, there are different deposits of different types of proteins that cause these illnesses, okay, within the cells. Ultimately, the proteins within the cells lead to stiffening and scarring. Emphysema is very preventable, and by and large, the first thing that we can teach someone is to quit smoking. Predictors of mortality, also on the slide here, are being male, being older, okay, O2, okay, if the person has to use O2, especially at rest, okay, that's a predictor of mortality. Frequent exacerbations caused by the things that are listed on the slide here can also be a predictor of mortality. And then patients or older adults with lower mortality have frequent hospitalizations. Okay, they are kind of in and out of the hospital. So chronic bronchitis is characterized by this chronic productive cough. Okay, the things that we talked about with the goblet cells, and they're trying to trap, and then they increase that mucus production. This is really a hallmark sign, constantly bringing up this yellowish, greenish sputum. The older adult can get really dyspneic with exertion, whereas with emphysema, the older adult can be dyspneic at rest. Someone with chronic bronchitis can also have peripheral edema. With emphysema, the patients do not. Exacerbations of chronic bronchitis have to do more with what the older adult's baseline status is, and then any worsening of that baseline status is considered an exacerbation. So if the older adult has a little bit more dyspnea, if they have a little bit more sputum production, if the sputum starts to look differently, okay, different color, different consistency, they could have an exacerbation. And in an emergency with a severe exacerbation, cyanosis can be present. Okay, also that tachycardia and labored breathing. Those would be things of a emergency. So with emphysema, the patients have a chronic cough, but it's non-productive. Okay, and that's really the main difference between chronic bronchitis and emphysema. Patients with emphysema also tend to have a lot worse gas exchange, so they have more shortness of breath at rest. Sometimes the patients get so short of breath that they can't even finish a meal and they lose lots of weight. Okay, and the picture here is a picture of a patient with emphysema, but also this patient has cachexia. You can see the prominent neck muscles, the barrel chest, okay, the 11th and the 12th rib are kind of poking out of the rib cage. Okay, so that's all signs of cachexia. Okay, he also probably would have clubbing in his fingers. Exacerbations of emphysema are characterized by being extremely fatigued or just absolutely wiped out. Also, labored breathing, and more often these patients in exacerbations become more cyanotic because they are already so hypoxic. All right, so to diagnose COPD, we have to rely on pulmonary function tests. The pulmonary function test basically measures airflow in and out of the lungs in various capacities. So the two that are important for COPD are the FVC, okay, which is the amount of air the lungs can hold with maximum effort, and forced expiratory volume. Okay, then that's the amount of air the lungs can expel in 1 second with maximum. These two values are calculated using spirometry, which we're going to go over in a minute. So basically, you divide the FEV1 by the FVC and determine the ratio. Okay, and the ratio then is the percentage of air in the lungs that can be expelled in 1 second with maximal effort. So basically, this is like the ejection fraction that we talked about in the cardiac lecture. It tells you the percentage of air that is expelled with each breath in 1 second compared to how much it can maximally, or that how much air that breath could maximally contain. In COPD, we check the FEV1 before and after bronchodilation. So if the bronchodilator significantly increases the ratio, then that means the older adult has more severe COPD. So to diagnose COPD using these pulmonary function tests, the primary care provider or the respiratory therapist really has to follow a few steps. To calculate FVC, which the patient takes a deep breath in with a mouthpiece, then you determine their pre-bronchodilator FEV1. So then we calculate the ratio, give 2 puffs of albuterol, then wait 5 minutes for that to kick in, and then we recalculate the FEV1. After we calculate the post-bronchial dilator ratio, so basically what we're looking at is if the ratio after bronchodilation is still less than 0.7, that's diagnostic of COPD. So I'm really just kind of giving more explanation of what here's on the slide. And the determination of the stage of COPD, we have to look at how much the FEV1 that the older adult has compared to what they should have breathed out. Okay, so it's a ratio of actual air breathed out, or it's a ratio of actual air breathed out compared to what that air, how much air should be breathed out. So here's the staging system used in diagnosing COPD, or diagnosing the stage of COPD using those FEV1, FEVC ratios. So you can see that the ratio of less than 0.7 in all of these stages is characteristic. But what differs in the stages is how much FEV1 the older adult can get out after the bronchodilation compared to what that amount should be. So in a person with an FEV1 to FVC ratio of less than 0.7, with about half of the normal post-bronchodilator FEV1, those would be in stage 2. It's kind of like the NYHA heart failure staging system, where you kind of get a higher number. Okay, the worse the condition is. Okay, so the higher the number, the worse the condition is. But the difference in the NYHA scale is that we're basing those heart failure stages on symptoms and how much activity it takes to reach the symptoms. And that this one, however, is a gold standard because the data is much more objective, because we actually have numbers through testing, okay, for this gold staging system. So the higher the number, the worse the condition. And the difference is based on objective data from pulmonary function tests, whereas the heart failure, NYHA, has to do with symptoms and a little bit more subjective staging. Other things that we can use to diagnose COPD are a chest x-ray. And what we're looking for on a chest x-ray are things that are listed on the slide. Okay, the first thing is a flattened diaphragm. Usually your diaphragm is dome-shaped, but with COPD it's more flat. Okay, remember that's one of the major muscles used for inspiration and expiration. Chest x-rays, we can also evaluate for pneumonias, and pneumonias are seen as infiltrates, okay, or little white blobs on the x-ray, and they appear in a lobe of the lung. Also, people with COPD are at higher risk for pneumothorax, and we'll look for pneumothorax on the chest x-ray as well. We also get an EKG because in people with really bad COPD and that increased pulmonary, or it can increase the pulmonary blood pressure. So when you have a real high blood pressure in the pulmonary circuit, that blood coming in from the right side of the ventricle, that right ventricle needs to push really hard against it and or against that pressure, and it will cause the right heart to strain or to become pretty enlarged. So with an EKG, we can see that it takes longer for electricity to get through the right ventricle, or that the heart is already enlarged. Okay, and that's called right ventricular strain or hypertrophy. We can also calculate or objectively determine the pulmonary blood pressure. Normally, we don't really care about the pulmonary blood pressure, except that when someone has COPD or other conditions of pulmonary hypertension, that can significantly affect their shortness of breath. And there are meds that we can give to decrease pulmonary blood pressure in patients who have characteristic shortness of breath. And often we'll do a right heart cath and check for their pulmonary hypertension. Treatment for COPD depends on what gold stage that the older adult is in. So in stage 1 is called the mild stage, and we usually prescribe a SABA or a SAMA PRN. Okay, and it's PRN for shortness of breath. And we're going to talk about SABAs and SAMAs in a few minutes. Basically, though, a SABA is a short-acting beta agonist, and a SAMA is a short-acting mucarinic agonist. And they have the same effect, okay, for the older adult in stage 1. They quickly open up the bronchioles when a patient becomes short of breath. So in stage 2, we also prescribe a SABA or a SAMA PRN, but we also add a long-acting, okay, a LABA or a LAMA. And these can be given once a day or twice a day, depending. It's also a good idea at this stage to add pulmonary rehab, because basically by this moderate stage, the older adult is really in a frame of mind to notice that the COPD is starting to affect their daily living, and they want to make things better. Stage 3 is treated the same as stage 2, but now we're adding an inhaled corticosteroid. And then stage 4 is considered end stage. Okay, they have everything in stage 1, 2, and 3, but they're also going to need home oxygen and some sort of palliative surgery to relieve some of those anatomical changes that happen in the chest. Or sometimes the patient will elect palliative care. No matter what stage the older adult is in, they need to be instructed of risk factors. Okay, so to avoid those risk factors, and they need to get their flu and their pneumonia vaccine. Those are very important things that we need to educate the older adults, no matter what gold stage of COPD that they're in. So this is your stage 1 medication plan for COPD. So I'm not going to read the slide to you. I'm going to tell you kind of as a case study. Right? So a patient who comes to the emergency room with shortness of breath and a diagnosis of COPD. The doctor orders a combo SAMA-SABA nebulizer for them. The SABA of the two kicks in immediately. So that's going to be like your albuterol or your lev-albuterol, and they'll work for about 15 to 30 minutes. By that time, the second, okay, SABA will kick in, the ipratropium. Okay, and that'll carry that older adult, okay, for about 2 hours. So basically, they're hit immediately, and then they have sustained bronchodilation with the combo, okay, of the SABA-SAMA nebulizer. Sometimes people are on these and they take frequent bursts of inhalers for rapid relief, but they can be given separately or given together. One thing that's really important about these SABAs are that they are sympathetic nervous system agonists. These are going to kick in your beta 1 and beta 2, okay, response. Albuterol is going to cause your beta 1 side effects, like your cardiac symptoms, okay, that are listed there on the slide, like your tachycardia, your tremor, your anxiety, your sweating. The alternative is levo-albuterol, which is much more expensive, but it's a beta 2 selective, okay, SABA. And it only works in the bronchioles. Okay, it does not work in the heart or on the skin to have those vascular effects. So if you have someone who happens to have palpitations, you can request the inhaler to a lev-albuterol, although albuterol is the gold standard. SAMAs are pretty safe. They don't really get absorbed out of the lungs, and they're pretty much no side effects from these. So LABAs and LAMAs are used for stage 2. LABAs are long-acting albuterols, and you'll notice that all of the beta agonists end in terol, T-E-R-O-L. So those are medications like your solumedrol, etc. Of those 3, albuterol is the shortest acting, and the other 2 that are listed on the slide are the long-acting ones. Okay, so your formoterol. LAMAs, okay, on the other hand, they all have opium, okay, at the end. Okay, so they're your ipratropium or your tiotropium. Both of these drugs are scheduled 1 or 2 times a day, depending on which drug you use, and they are not rescue inhalers. They're not going to help someone who is drastically short of breath. And both of these are given as dry powder inhalers. Okay, so your long-acting beta agonist, your LABAs, and your long-acting muscarinic agonist, your LAMAs. The most common side effects from corticosteroids is oral thrush. Okay, and oral thrush is a yeast infection in the mouth, and it's caused by the steroids knocking out the IgA and the inflammatory response in the mouth. The mucous membranes, if you remember, are covered with IgA, and steroids block those so that there's no protection against things like yeast. So your mouth becomes a petri dish for whatever's around. So after the patient takes the steroid, it's really important that we instruct them to rinse and spit after each dose. If they swallow, then they can get esophageal thrush, which is really painful and very hard to treat. So it's important, swish and spit out water. Rinse their mouth and spit it out. And also to increase frequency of oral care. If the patient has thrush, we use nystatin, which is an antifungal, and nystatin comes in a mouthwash form. Usual doses to swish 10 cc's and then swallow that. Okay, so they swish it around their oral cavity and they swallow the nystatin, and that's to carry that antifungal effect into their esophagus for extra protection. The patients need to clean their tongue off good, and we need to monitor for heartburn and sore throat, because things like that can mean that thrush is spreading into the esophagus. Another option for treating COPD in stage 3 or 4 is theophylline. And this is a methylxanthine drug, which is essentially a synthetic version of caffeine. All right. It releases bronchial smooth, it relaxes the bronchial smooth muscle, and it promotes pulmonary vascular dilation. It relieves pulmonary hypertension by that pulmonary vascular dilation. We only really use it if if the patient isn't adhering to their inhaler. Maybe the inhalers are too expensive, or they can't use them correctly, even after we educate them, and they don't have a nebulizer or a spacer, or they can't use those. Then we provide prescribed theophylline, okay, for the older adult. We really tend not to use it very often because it's a pretty dangerous drug. It has a very narrow therapeutic window, so blood levels need to be monitored frequently, and we need to watch very closely for side effects. And the side effects are listed on the slide. Basically, the side effects are like the patient drank too much coffee. So what do we do with a patient that comes into the ED with an exacerbation of COPD? So maybe they have some increased sputum or a little bit more cough, like chronic bronchitis, or they're really more short of breath. They're not really able to do anything like emphysema. They might have hypoxia and cyanosis, tachycardia, increased workload of breathing. So if the older adult has any of these things, it's really important for us to tell them to get to the ED. And in the ED, they're going to have some tests run, like a chest x-ray, an EKG. There's going to be some blood work drawn. A troponin level will be drawn to rule out an MI. And while in the hospital, the LABA and the steroids will be given. But often the ED will add more frequent SABAs and SAMA nebulizers, usually with a duoneb, which is albuterol and ipratropium. In the ED, systemic glucosteroids will also be added, like prednisone or salumedrol. We used to give, even at home, someone with COPD, systemic corticosteroids, but we really don't do that anymore. We've replaced the systemic corticosteroids with inhaled steroids. And there's really a benefit with the inhaled steroids because they stay right in the lungs, so there's no systemic side effects. And they're much more effective on a day-to-day basis in the home. But in the hospital, we have to give more powerful steroids, either by mouth or IV. So we start someone on a systemic glucose or a steroid. We also, a lot of times, start empirical antibiotics just to make sure that there's not an infection going on somewhere in the lungs. We give an expectorant to loosen thick secretions and to help the patient cough better, and also to rehydrate them with IV fluids. And this is all dependent on how much respiratory support we need to give them, uh, along with increased oxygen. Okay, because usually by this time, when they get to the emergency department, they need a little bit more O2. Okay, so we might bump up those liters 1 to 2. Okay? The older adult may also need BiPAP or mechanical ventilation, depending on how bad the exacerbation is. So things that the nurse needs to monitor are for any kind of respiratory symptoms, and we need to, or any worsening or new respiratory symptoms, and these need to be monitored very closely. Things like cough, shortness of breath, sputum. Also monitor mental status, okay, and that means that the brain is not getting oxygen. One of the earliest signs of a COPD exacerbation and of hypoxia in an older adult is declined cognitive status. All right, so it's really important to monitor that mental status. We need to monitor energy levels, the smoking status, how the older adult is adhering to inhalers, like the techniques, the times they're taking them, which inhalers, how often maybe that rescue inhaler is being taken. And just because the older adult's been on inhalers forever, it doesn't mean that they really know how to use them. And the older adult should show the nurse how they actually take the inhalers, so that if we need to re-instruct the older adult on the use to make sure that they're getting the full effect of the medication, we can do that. We also want to monitor and educate also about oxygen safety, things like falling over the tubing, if they're smoking when they're on the oxygen, do they have a fire extinguisher in the home? Things that the nurse is going to do then. First of all, the goal with COPD or with any chronic disease is to get the older adult to do their own stuff. So we need to provide them with what they need in order to be able to do that. Remember, we always want the older adult to be as independent as possible. So it may be getting a spacer to help with their inhalers. We need to facilitate home oxygen. The nurse participates in this, but usually the respiratory therapist, okay, helps also get home O2 set up for the patient if the patient needs that. Follow-up needs to be done frequently, especially if they're going to be outpatient. When an older adult is discharged from the hospital with chronic disease, some hospitals have a different program that's set up in which they'll call patients a couple of days after that discharge to see how they're doing. And the goal really is to make sure that the older adult is complying with the treatment plan that they have, and that they have follow-up. And basically, it keeps them from coming back to the hospital. Okay, so a lot of those programs are called like traditional or transitional care programs. We want to also make sure that the older adult is using their MDI, their meter dose inhalers, and we should always make sure that they're using a spacer with those to get the full dose. With oxygen and nebulizer, we want to make sure that the tubing is getting changed, following any policies, hospital policies, and we want to collaborate with respiratory therapists to make sure that these things are followed. Pacing nursing activities to prevent dyspnea and shortness of breath is important also. We shouldn't go in to provide all of our care all at the same time. If the patient's short of breath, then we should let them rest. Or we can give a dose of ASABA first if we're going to do something that requires a lot of effort that may cause the older adult to have shortness of breath. So we also want to perform chest physiotherapy and repositioning to mobilize secretions. And this is when we cup our hands or we pat along the sides very forcibly and quick. That's what the picture is depicting. It's chest percussion. Or we could reposition the patient. So we move the patient in any position to help mobilize secretions. And then we put the head down and the feet up in the Trendelenburg position to help gravity kind of get that stuff out of their lungs. We want to minimize O2 consumption by making sure that the patient isn't anxious, they're not in pain, and they're not performing excessive, or we're not having them perform excessive activity. Oxygen can be given for COPD, but we can't give a lot of it. The goal with a COPD patient is never to get their oxygen up to 100%. Okay? If the COPD patient has a range of 88 to 93, they're doing good. We really go by symptoms. And if they're not short of breath, then their oxygen is set at the right level. If the patient is sleeping or has a decreased level of consciousness or is unconscious, then we need to be real careful with oxygen. We don't want to give the older adult like a big shot of oxygen because it'll wipe out their drive to breathe. They really don't have that backup system to breathe. Okay, so remember we talked about drive to breathe is dictated by a high O2 level or a low O2 level. So most COPD patients' breathing is driven by that low O2 level. We want people with chronic bronchitis really to cough up secretions. So we don't give cough suppressants to people with chronic bronchitis. The only time that we would give these is if they can't sleep or if their cough causes things like severe shortness of breath, dysrhythmias, or gagging. We want to make sure that we keep everything really simple. We don't want the patient to work hard at all because that burns up energy. We also want to help make sure that the COPD patient has access to home O2. And that's very important. Not every patient with COPD will need it, but those in stage 3 or 4 will. They might also need oxygen use after any exacerbation that they come into the hospital with. So what we do to see if someone qualifies for home O2 is we perform a 6-minute walk test. We walk the patient around, we walk with them, and we constantly monitor their O2 saturation. If it drops below a certain level or they have certain symptoms, then they're going to qualify for home O2. And home O2 is usually set up by the home healthcare agencies. They'll drop off stuff at the patient's house. They'll use like a concentrator. In the picture is an example of a cylinder or liquid oxygen. The home O2 company will also drop off and deliver devices like the cannulas and portable oxygen supplies so the patient can leave their home. With home oxygen, safety is very important. So we want to make sure that there's no flames around the patient. One thing I experienced a lot in a lot of my home O2 patients is a patient cooking with the stove with an open flame while wearing their oxygen. So we want to make sure that they avoid doing that. Electrical devices need to be in good working order. They all need to be grounded. And the patient should wear cotton clothing, no wool or fleece. Also, of course, with open flames, there should be no smoking around oxygen. So these pictures first are a concentrator, which is on the left side of your screen. And with a concentrator, it's basically they're taking the oxygen out of the room air. They concentrate and pushes it out through the nasal cannula for oxygen use. And the other picture on the right side is a portable device. And this is liquid oxygen that comes in a container so that the patient can leave home and go out and still have access to their oxygen. The goal of COPD management really is self-care. So nurses need to teach the older adult what to do to stay safe and healthy. So vaccines and smoking cessation are two of the most important things that we can do to help keep our older adults independent and with safe care. We want to also teach to stop any exposures and to prevent any acute respiratory infection. Other thing is to teach about lung cancer screening. A lot of the same things that cause COPD cause lung cancer. So the older adult with COPD is automatically at high risk, and they should go in and have chest CTs done like every 1 to 5 years, depending on how severe the COPD is or how much smoking that they've done. If the older adult has shortness of breath, they need to know how to manage this at home. So it may simply be giving themselves their inhaler, their SABA or their SAMA. We can also have the older adult sit in the tripod position for breathing. That's what the picture here is depicting. And what this position does is it forces the rib cage to elongate and stretch out, and this allows for more ventilation. Pursed lip breathing also helps keep the O2 in longer, so more of it can be absorbed through the alveoli. And I'll show you that on the next slide. Supplemental oxygen also can help with shortness of breath. So here's a picture of pursed lip breathing. Basically, the patient blows out very slowly, and so that the blowing out slowly, they're holding on to more of that oxygen in their lungs for a little bit longer, while still getting that carbon dioxide out. Damaged alveoli need some time for O2 to cross over, so by letting that breath out slowly through those pursed lips, helps oxygen stick around in the alveoli longer. So things we might not think about teaching are diet. The older adult with COPD needs to be on a low carb, high protein diet. Carbohydrates are important to restrict because they combust down to carbon dioxide. So the patient will retain more carbon dioxide if they're eating a lot of carbohydrates. They are not restricted specifically for weight loss. It's for the CO2, the breaking down and forming CO2. Protein needs to be soft and easy to swallow. Otherwise, the older adult may really burn themselves out and get very fatigued just after a few bites, okay, of protein. A few bites of steak might make the older adult very fatigued, and they may stop eating at that point. Also, to teach the older adult how to use inhalers correctly and what the meds are for, especially which ones are rescue and which ones are schedule inhalers. Provide for oral care, okay, especially with those steroids. We always instruct the older adult, or instruct anyone who's on inhalers, to take the SABA before the steroid inhaler. So take the SABA before the steroid inhaler. And this is very important because the SABA is to help open the lungs as much as possible so that the steroid will get deep into the lungs and work more effectively. We also should encourage the patient to attend pulmonary rehab. Also, back up to SABAs. A SABA can also be given before one eats, before the older adult eats, to improve food intake, okay, to help open up those passageways. So here are the steps for the use of a spacer here on the slide for you. Make sure you review the use of a spacer before you teach the patient so you know that you're doing it correctly. And proper use is really important so that they can get the full dose of the medication. And then here's a dry powder inhaler. It comes in a discus device that you see on the slide there, and you activate it after opening it. Okay, so you kind of put this little switch, I guess. The pill comes out. You open it. It pierces, and then the patient takes a deep breath in on the mouthpiece. Now, the powder comes in a form of little tiny pills that I talked about. So the pill gets punctured and it releases that powder, and the patient inhales it into their lungs. These mouthpieces also have a little screen. So the only thing that the patient does inhale is the actual powder. The pathophysiology for tuberculosis is really unlike any other infection. The organism that invades the lungs is Mycobacterium tuberculosis. What happens with TB is that when a patient breathes in this organism, it travels into the lungs apex. When it gets to the apex, it triggers a local inflammatory response, just like any invading organism would. But the TB organism is pretty darn smart, and it uses the body, the host body's own inflammatory response. Okay, and by doing this, the tuberculosis organism forms a wall around itself. And as the TB organism reproduces and causes a larger infestation, that wall areas, or what we call a granuloma, increases in size. The organism sets up shop and sits there. The organisms, or the bacterium, the Mycobacterium tuberculosis, will reproduce. The granuloma will get bigger. The patient will have symptoms. Then it will lie dormant for years or even decades. And within the granuloma, as the TB is eating up all of the tissue, there's a lot of necrosis that happens in those apex of or apices of the lungs. When the TB organism lies dormant, the symptoms, the signs and symptoms of TB resolve, but it becomes reactivated when the patient's immune system drops or when some big stressor happens to the host or the individual. And then the granuloma starts growing again because the TB organism starts to replicate again. So TB is one of the most infectious diseases. It spreads really easily as one of the most infectious diseases actually in the world. So this is what a lung with tuberculosis looks like. As the TB organism is invading and spreading, it starts out as a little tiny granuloma up in the apex of the lungs. You can see that little spot in that very first picture there. The granuloma hollows itself out in the middle. It causes necrosis, and then over time, you end up with these granulomas sort of growing everywhere until they lie dormant. Okay, so it's the picture here is a little bit of the progression in an actual picture form, and then an actual X-ray form also on the slide that we'll talk about. As the granulomas are getting bigger, they start to invade the local tissue and the blood vessels, and those blood vessels start to tear. And that's what leads to that bloody sputum or that coughing up of blood, which is really a hallmark sign of tuberculosis. It's because these granulomas have broken open, and a bunch of those, because the granuloma has broken open a bunch of blood vessels in the lungs. When the TB reactivates, then it can spread to other parts of the lungs. And that's kind of what you see in the actual autopsy picture here. It can also get into the bloodstream and travel to other parts of the body. That's why you hear about tuberculosis being maybe in hip joints or in other parts of the body in other organs. The risk factors for tuberculosis, you can read, they're here on the slide for you. But really, any situation that impairs immune system function or that forces an individual to live in close contact increases the risk of contracting tuberculosis. Remember, it's one of the most infectious diseases in the world. Of course, in order to get tuberculosis, the individual has to be exposed to someone with active TB. So not when the granulomas lie dormant. They have to have active signs and symptoms of tuberculosis to be infectious. However, if the person does have, a poor immune function, they live in a crowded situation, they come into contact with somebody with active TB, they will get tuberculosis. It only takes one organism, okay, to be breathed in to cause someone to have TB. An important note also about TB is it is the #1 killer of people who have AIDS. So when we have or we care for an AIDS patient, we do screen them for different pulmonary symptoms. Other facts about TB also are listed here on the slide, but TB is spread by aerosolized secretions. So the patient doesn't necessarily have to cough or to sneeze on you. They just have to be breathing or talking. And that's a way that the microbacterium tuberculosis gets into the air. And if you breathe it in, that can cause you to contract tuberculosis. However, remember, the person has to have an active infection. The tuberculosis has to be active in order for it to be contagious. If the tuberculosis is dormant and is in that granuloma, it can't be spread. Usually older adults, if they come up with a positive tuberculosis result, it's because they've had it in the past. There's very few older adults that have their first infection when they're older. Anybody who's at high risk needs to be screened on a regular basis. And this is done by a 2-step process. It's a MAN-2 test. All right, so we do a 2-step screening. The first, we provide a MAN-2 skin test. And what we look for with this is the induration. If it's over a certain diameter, that would be a positive MAN-2 test. If it's inconclusive, or the skin test didn't really take, maybe because it was injected too deeply, okay, then we do a second step, which is a chest x-ray. So if a MAN-2 test didn't take, or it becomes positive with an induration, we always get a chest x-ray. So that's the 2-step process. One very important thing about MAN-2 test is even if it's positive, it doesn't mean that that particular person has TB. It's a real sensitive test, but it's not very specific. So we can respond to something that, or that skin test can respond to something that looks like TB, or it could be dormant TB, or it means, but it doesn't really mean that they're positive for that active tuberculosis infection. Okay, so that's why we need to get the second step if it comes back positive. Okay, or inconclusive. On the chest x-ray, what's looked for is infiltrates in one of the upper lobes, or those apices. Almost nothing can live in the upper lobes of our lungs except for the tuberculosis bacterium or tuberculosis organism. So if we see an infiltrate there, we're pretty sure that the patient does have tuberculosis. So with the MAN-2 skin test, we look for, I mentioned this on the last slide, we look for the diameter of the induration. Excuse me. And the induration is that hardness. So that's when the nurse, or when you have your TB test read, they kind of run their finger over the test site, because the nurse is palpating the site to look for that hardness. It's not the redness around the injection site, it's not the bruising, it's that hard lump. And what that hard lump means is that the T cells are fighting the infection. So with older adults, we go with a induration of 10 millimeters. Okay, so 10 millimeters is the cutoff. All right, so if they're 10 millimeters or more, that means they have a higher risk for tuberculosis, or they've had some exposure in the past. If the older adult has HIV or is in contact with someone with tuberculosis, active tuberculosis, or they're an organ transplant, we might go with a smaller induration as a positive test, because we want to be more cautious to catch things earlier on in people in those categories. So 10 millimeters is what you need to remember for a positive MAN-2 in an older adult. And on the right, again, you'll see a chest X-ray. The picture on the last slide or a couple slides ago was like an autopsy picture of a tuberculosis lung. This one is a chest X-ray, and you can see that they have large infiltrates in the upper lobes. Okay, or this patient would be positive for advanced TB that was detected on a chest X-ray. So classic signs of tuberculosis are really those first 5 that are in red. If we see 3 or more of these signs and symptoms in the same patient, then we really need to go on for diagnostic testing for tuberculosis, active tuberculosis. The MAN2 test is not a diagnostic test for TB, rather it's a screening test. The chest X-ray also is used for screening. Then we'd have to go on to so we get these screening tests, we look for signs and symptoms. If it's a positive screen, if it's a positive symptoms, then we would go for diagnostic. And we're going to talk about the diagnostic for tuberculosis on the next slide. So to diagnose tuberculosis, we do this with an acid-fast bacillus sputum culture. And it's really a special sputum test that is run with a special type of dye or staining. Okay, and you can see we perform it if the screening tests are positive or inconclusive, if the patient is symptomatic, or if there's high prevalence of tuberculosis in the community, or the patient lives in close contact with others. Anyway, the acid-fast bacillus sputum culture. To do this, it requires 3 consecutive AM sputum samples. So 1 sample every morning for 3 days in a row. And then that sputum is cultured to check for positivity of the tuberculosis organism. We have results in about 48 to 72 hours of this test. While we're waiting diagnosis, or if the patient's presenting with symptoms or positive screening tests, they do need to be in airborne isolation, say if they're in a facility, or they need to be quarantined at home until we get these results, these diagnostic results back. The TB Gold, okay, the quantiferon TB Gold test is a blood test, and it replaces the acid-fast bacillus sputum test. So we can do one or the other of these. So either sputum or a quantiferon TB Gold. So the blood test is the serological evidence of the tuberculosis microbacteria. The results are back much more quickly with the quantiferon TB Gold test, so we can start treatment much quicker. But however, this test is much more expensive. The culture of the sputum is very cheap to run. The quantiferon TB Gold test is very expensive. Other things that we might get for diagnosis for tuberculosis are routine blood work, like a CBC. We're checking for, the white blood cell count, maybe the hemoglobin. If they have a lot of bloody sputum, make sure that they're not anemic. A CMP is helpful if we need to start meds, because the meds do really impact the liver. So we want to get a baseline liver panel. And then the SED rate is an overall marker of inflammation, and it can also help with treatment or to find out where they're kind of at in an active case of tuberculosis. Medications for TB, okay, there's 4 different types or 4 categories. The person, okay, the individual that has active tuberculosis is diagnosed, usually starts off with all 4 to begin with. And as long as they're clinically improving, after a certain period of time, usually about a couple months, then they'll get switched down to the 2-drug regimen. So these 2 drugs are for all phases, okay? They are very hard on the liver, so it's really important that the patient does no drinking at all when they're on these. So these 2, okay, will start with the 4, and the other 2 are going to be on the next slide, but you'll start with the 4, and then they will remain on these 2 medications. One other thing to note with rifampin, okay, rifampin makes the urine and sweat turn orange. Okay, this is a normal side effect of the medication. It doesn't really cause anything except for turning orange. However, it also can make contraception ineffective. So if you have a younger person that's being treated for TB and is on rifampin, you need to make sure that they are using some other type of birth control. All right, so you'll see the some of the other things that we need to worry about with these medications, like to take, on an empty stomach or with food. As I said, very hepatotoxic, very hard on the liver. That's why it's important to get those baseline liver function tests in that CMP. Neurotoxic, okay, and absolutely no alcohol. All right, and these are the other two drugs that we use initially, but then they're dropped after a certain period of time if the patient is improving, if their symptoms are improving with the treatment. Pyrinazide and ethambutol, okay, are their names. Pyrinazide is hepatotoxic. Okay, so again, the patient should have no alcohol consumption when they're on this. And ethambutol is the only med that is not hepatotoxic, so it's not going to damage the liver. However, it can damage the retina. All right, so very frequent vision screenings, like every 6 months, is important to instruct patients about when they're on all four of these drugs. Okay, so you'll see some other of the indications of the medications on your slide here as well. Treatment for tuberculosis can last for up to 2 years, depending on how quickly that tuberculosis organism goes dormant, okay, or it gets eradicated. But it can last and be active for quite a while. Tuberculosis is a reportable disease to the state. So every patient who has contact will need to be screened as well. So that's anybody in the household, anybody that the patient works with. All right, so we have to screen close personal contact. During the 2-year treatment, the patient will need to come in and get sputum cultures about every 2 to 4 weeks. Okay, and that's checking for, if the tuberculosis is remaining active, if it's responding to medications, or if it goes dormant. And they'll need to screen for resolution of the TB. A patient is considered contagious until there's 3 negative cultures, okay, those sputum cultures, or they have a negative quantiferon TB gold test. Monitoring for TB is going to really focus on monitoring for active infections, a lot of the things that we've talked about already, and to make sure that we're monitoring to make sure the infections are resolving once treatments are started. So we need to make sure that the patient and that we ourselves know what the signs and symptoms are for tuberculosis and who's in those high risk groups of patients. Long-term care is really, close contact. So TB, if a person in a extended care, a long-term care facility does develop tuberculosis, it can spread very rapidly. And that's one of the reasons why every new resident to a nursing home is screened first before they're allowed to come. Okay, and if the screening is positive or if they have symptoms, okay, they're not allowed to come, or they get treated for it, and the tuberculosis has to be either eradicated or responding to the treatments before they're allowed to come into the nursing home. Another thing, as a tuberculosis organism is very adaptable. So patients really need to be instructed, and we need to monitor that they are taking each dose of their medication every day at the scheduled time. If the patient's taking the medication skip just one dose, the organism can become resistant to it. Okay, so they really have to stick to that treatment regimen. And resistant means that the drug will no longer be effective for their tuberculosis anymore. All right, and because of this, um, it's it's very important. And in many settings, the patients don't even give the drugs to themselves. A lot of times, we may not say, "Okay, well, here's your prescriptions. Go home and take these." But rather, a nurse will come to the home or a nurse will come to a facility and actually give the medication to the patient and make sure that the patient swallows it. When I was doing home care in a county that was south of here, we had many tuberculosis patients. I didn't necessarily see any in an active stage, but they were quarantined at home. And I worked very closely with the health department nurse. One of her jobs was to actually go to these patients' homes and give them the medications to make sure that they swallowed them and took them at the scheduled time. So that's in areas, especially with that have high tuberculosis rates. We also need to make sure that we're monitoring for the side effects to the medications. We need to monitor different test results, those liver function tests, the CBCs, any pregnancy, if a female is of childbearing age and is on these medications. And then we need to make sure that we really explain about that orange body fluids, that it's nothing to really worry about. It's just something that happens. All right, and then also we need, as nurses, we need to monitor the effects of social isolation, like depression. Okay, because patients with tuberculosis do have to be isolated, especially active tuberculosis. When I take students down to Chile, one of the hospitals that we go to is an old actual TB sanatorium in that country, but they have a wing that cares for tuberculosis patients. In that country, when somebody is diagnosed with tuberculosis, if they don't have the resources or they have a really active case, they are actually hospitalized and they are given medications. And sometimes the patients do stay there for up to 2 years. As for isolation, we need to isolate tuberculosis patients, and this is very important to decrease the spread. So they're in airborne isolation. If at home, they need to self-quarantine. They need to be away from all family members, okay, until their tests come back negative for TB. So in the hospital, airborne isolation, nurses need to wear, anybody that walks into the room needs to have an N95 respirator mask and wear goggles, and they need to be in a negative airflow room. It's the same thing that we're seeing with the COVID-19 isolation precautions in the hospitals now. We can administer medications, okay, or we need to administer those medications without fail. We could also give bronchodilators for respiratory symptoms of patients. We need to avoid biologics that block the T cell receptors. If we remember, T cell receptors response is what's keeping that granuloma contained. So the host T cells are really helping to keep that granuloma intact and the TB walled off. If it breaks open and the TB that kind of comes out and it spills, the infection can reactivate and the patient can become contagious again. So biological agents block certain aspects of that T cell response. So it can cause that granuloma to not hold together and reactivate that TB for reinfestation and the patient to becoming much more contagious. And then we also, as nurses, healthcare providers, should make sure that we're providing emotional support, and that's very important. There is a lot of stigma associated with TB, and that's from generations ago when TB patients were often taken to these TB sanatoriums, even here in the United States. And it was the home that they would live in, sometimes, like I said, for up to 2 years or forever, and many people died in the sanatorium. The other thing with providing emotional support is the isolation alone, either if the patient is at home or in the hospital, in isolation precautions to provide for that emotional support, screen and monitor for depression issues. And then as nurses, we need to teach the importance of the medication adherence, okay, due to that drug resistance. And if the patient is exhibiting any kind of side effects, then we need to call the provider immediately. Don't just stop the medication, okay, for side effects. It's calling the doctor or the physician immediately. And we need to also teach the patients how to prevent the spread of TB. You have things listed on your slide there. Also, the signs and symptoms of reactivated tuberculosis. Sometimes that reactivation can start out with feeling like the flu, okay, plus kind of all of the things that we've already talked about, signs and symptoms of tuberculosis, like the night sweats, fever, bloody sputum. And that is it for the respiratory lecture. You all have a great day.